The site healed very well with good attaching keratinized tissue, and the CT scan also showed that we have adequate bone quantity and quality, but that does not mean that you can immediately place an implant in a flapless approach, because a flapless approach will usually, for a molar position, will take away most of the good attaching keratinized tissue, and I think this is not very advantageous. So a system that I use in order to decide whether I can go with a punch technique or if I need to reflect a flap, I use this closing solution through the guide, and I create a little stamp. So I take my actual punch and I dip it inside this closing solution. I pass it through the surgical guide, and I don't go through the tissue. I just stamp the tissue and I see where it lands. And if I have enough attaching keratinized tissue, I would certainly go with a flapless approach. In this case, it's a little bit borderline, so I'm going to choose the half punch approach. And what does that mean? I'm going to make a mid-crestal incision, reflect a full thickness flap on the buccal, but leave the lingual tissue attached, and then use my punch. So technically, I'm only punching the lingual flap, and that will preserve more attaching keratinized tissue on the buccal aspect of the implant. So this is why I call it the half punch approach. The first drill that I use is a twist drill that has a 2 millimeter diameter. I then place a direction indicator and take a radiograph to make sure that I have a good trajectory. So you can see the direction indicator is right in the middle of the guide. You can see the buccal plate that has regenerated, mostly on the mesial aspect. Once I confirmed that the trajectory of the implant is proper, I can continue with the additional drills in this particular protocol. So I'm going to start with a narrow diameter drill and slowly expand the osteotomy until I reach the final diameter that is 5 millimeters. At this point, I make sure that there's no granulation tissue, that the osteotomy is clean, that it's bleeding and ready to receive the implant. And that's really the beauty of computer-guided surgery. The positioning, the trajectory of the implant, the final height of the implant has already been determined. So all I need to do is follow the protocol and place the implant through the guide. And that's what I call a fully guided implant surgery. So the implant is positioned through the guide and oriented properly according to the timing of the implant, meaning the position of the connection. And after placing a healing abutment, you can see that once I suture the tissue, I have a lot of attaching keratinized tissue, and suturing should be relatively simple, using gut sutures in an interrupted technique. I'm going to wait 2 more months for this implant to heal, for the soft tissue to mature, before I check the integration of the implant and taking impressions for a final crown. I hope you found this process and this training helpful, and I hope it made sense to you that every step builds on the previous one. I showed you the extraction process, the bone grafting, the regeneration of the buccal plate, the use of growth factors, membranes, and the suturing process. And I also showed you the planning and how I decided on the ideal implant positioning. In the third video, I showed you the actual implant surgery, and I showed you how this whole process was relatively simple and very, very accurate because I did a lot of planning before. And now this patient can benefit from a well-positioned implant and also a very safe procedure.